Hi, my name is Arthur Korotkin. I'm a retina specialist at the Eye Center of Northern Colorado in Fort Collins, Colorado. And today I'd like to show you my technique for repairing a macula-on retinal detachment due to a giant retinal tear in a phakic patient. At this point in the surgery, a 41 band had already been placed on the eye and a core vitrectomy was performed. The kenalog flakes that you see floating around had been previously used to stain the posterior pole and confirm a pre-existing PVD. Subsequently, perfluorine is added to stabilize the macula and prevent the expansion of a retinal detachment intraoperatively into the macula. During this step, the infusion pressure is lowered, and you will see that will become significant in the next segment. For orientation purposes, this is the right eye, and you'll see the retina flopping around superiorly on the screen, at the top of the screen, which is the nasal retina, and the surgeon is sitting on the screen left. In the next step, I will tighten the scleral buckle, which again had already been placed on the eye previously. At this step, I'm trying to achieve a good support height. You will see that while I lowered the infusion pressure while putting the perfluorine in, I neglected to raise it as I'm starting the next step, and small choroidals are forming. This, in this case, is not a problem as the infusion pressure is raised again. You will see these choroidals disappear. This is probably the next most important step, and I spent quite a bit of time in shaving that peripheral vitreous base to give it a crew cut. I'm really spending most of the time, or all the time at this point, avoiding the area of the tear itself, and really removing any vitreoretinal traction 360 degrees. I really, having the scleral buckle is a significant benefit in this case because the retina is already indented. It doesn't require an assistant to indent, and you can move very carefully and more quickly at this point through the case. And at this point, we're getting to the inferior edge of the tear. The edges of the tear are a little bit curled, although there's no significant PVR, which is fortunate for the patient. I like to trim these edges as best as possible in order to have a flat surface to reattach. And in this case, I'm getting a little more movement of the retina than I really would like to see, and that can be combated in two ways. One is to change the aspiration settings to less aggressive setting. Another is to increase the perfluorine level higher, but you are running a risk of seepage of perfluorine behind the retina in this situation. The next step is to mark the edges of the tear with endocautery. This is also a very important step because once the perfluorine is added and the retina is flat, you really can't see the edges of the tear very well. I try to use the lowest possible setting on the endocautery power, and I also try to touch the retina in spots, and this is all to avoid curling the edges of the retina and puckering those edges, which I think can affect the chances of reattachment. I want to have everything as flat and as clearly visible as possible. I also try to mark carefully the very edges of the tear, almost out to the aura, because sometimes those are easy to lose once the retina is flattened by the perfluorine. And the next step is also going to be very important. It's going to be trimming the vitreous gel over the actual tear. I also like to trim the anterior retina in order to avoid having a segment of ischemic retina, which will then start creating VEGF and other growth factors and may give you problems with neovascularization later on. It's not a huge concern, but I really like to minimize the risk of that. And at this point, I really make sure that there's no vitreoretinal traction anywhere. I particularly spend quite a bit of time at the edges of the tear, because those are places where you can still have a significant amount of vitreoretinal traction. I really like to relieve those. Sometimes I have to cut out just a little more retina in order to do that, but if that accomplishes the goal of relieving all the traction, that's not an issue. After all the vitreous gel has been trimmed and there's no residual traction, perfluorine is then added up to the lens iris diaphragm. And this I try to do very slowly, in a very measured fashion, while maintaining an even edge of the perfluorine BSS interface. You really want to do that in order to minimize the risk of seepage of perfluorine behind the retina, which is not a fun thing to do, removing perfluorine from under the retina later on. You will also see in this segment that I'm tilting the eye to place the giant retinal tear superiorly, and that is done for two reasons. Number one is to steamroller that fluid out from under the retina, and number two, to minimize the risk of seepage of perfluorine under the retina. At this point, you'll see that the retina is nicely flat under that perfluorine, and that will allow us to proceed on to the next step, which is laser. For the laser portion, I use a curved 23 gauge endolaser to perform photocoagulation all around the previously marked edge. Having that cautery marking is indispensable for finding all the edges and making this step easy for yourself. And of note, I'm using all 23 gauge instruments for this procedure. You may have noted that there's a significant amount of cross reach with these instruments. However, the lens is not striped during the procedure because the vitrector and the cautery had been previously bent to go around the lens, and that will be a subject of a later video where I'll demonstrate that technique. But that allows more convenient cross reach without the significant risk of striping the lens and affecting the view, as well as giving patient the cataract later on. And this is the optional part of the case. I always make sure that the laser extends all the way out to the aura at the edges of the giant retinal tear. The question is whether to laser the rest of the retina 360. An argument can be made that there's already a 360 buckle surrounding that area and you don't need to do that. I think that the morbidity of doing that is low, and you're buying yourself a little extra protection for the retina. At this point, an air fluid exchange is being performed. I'm using a soft tip cannula with a silicone tip that had been slotted in the end, and medium extrusion. If the tip engages the retina at any point, that slit allows me to break the vacuum without having to traumatize the retina. This is a very important step because I want to make sure that I'm removing all the BSS that is above the perfluorine without aspirating any of the perfluorine just yet. That maximizes the amount of perfluorine that pushes down on the retina, and also minimizes any seepage of BSS. It's important to really take your time at this step. There's always a significant amount of fluid that remains anteriorly at the back of the lens and the pars plicata that will eventually seep down. Oftentimes I'll mix the gas and come back and aspirate the rest of the fluid. And as I'm doing the air fluid exchange, even as I'm going lower and lower, I always come back to aspirate the fluid at the top of the retinal tear to minimize the risk of slippage. And at the end, this patient had a very good outcome, maintaining a 20/25 phakic vision at 3 months post-op. Thank you for your attention.